So, good afternoon, everybody. The Global Andrology Forum and Turkish Association of Urology organized a masterclass on micro-TESE, and with the title "Success Behind Successful Outcome: Secrets Behind Successful Outcome." Professor Agarbal, chairman of the GAV, initiated this program, and we are more than happy and honored to organize this program together with GAV. The structure of the program is we have 6 talks. All of them are pre-recorded. Then afterwards, we are going to discuss some cases, and the panelists will discuss the cases presented by the moderator. So therefore, thank you very much again, Professor Agarbal, for collaborating with us, Turkish Association of Urology, and I turn the podium over to you for the welcome address.
Thank you very much, Professor Atish Kadiolu, and I will call you Atish. And good morning to everyone who is attending this program from Cleveland, Ohio. Today is Friday, and here it is 11:30 a.m. in the morning. So let me welcome you by sharing this small presentation, which will allow us to walk through this program very quickly and explain what we have planned. So let me just share this. So I'm the director of the Global Andrology Forum, and I'm going to give a very brief introduction about our organization. We are an online international research group, which was started about 2 years ago. Our goal is to conduct the highest quality of research and to write cutting-edge articles and to promote educational and research activities, which we are doing today. Our membership in the last 2 years have grown to about 572 clinicians and researchers interested in the area of andrology from over 78 countries. And this number is growing every single day. We would welcome each and every one of you to join. Go to our website, Global Andrology Forum, www.gaf.com, and you will be able to apply in few minutes. Our membership range from very junior to senior clinicians and researchers, with many of them have more than 15 years of experience, as you can see. And then we have younger clinicians and researchers as well. And the overwhelming membership is interested in conducting cutting-edge research. So you can see almost 90% of the people who are joining, and this is why they are joining, is that they want to learn, they want to conduct the high-level research in the area of infertility, in the area of sexual dysfunction, and that is why they are joining with us. There are many benefits to those who become the member. The membership is free. There is no fee of any kind for training, for research. Everything is completely free. And we have a lot of mentors who are available to train each and everyone. Actually, the research is conducted by clinicians who have no background in the research, but they go through a very thorough, very regimented, very well-planned, very thoughtful program for training, which allows them to undertake very difficult type of research projects, which are being conducted every single day. Our program in just 14 months have published now almost 28 research articles and a large number of reviews and meta-analysis that is unparalleled in the history of the world. No other institution, no other country has this distinction that has come up from our members. So we feel that giving the opportunity, we can do wonders. And this is our management team. These are the people who are advising us and guiding us on a day-to-day basis. So today I come here to present to you very quickly the program, the scientific program of a webinar on micro-TESE, Secrets Behind Successful Outcome, a masterclass for novice and experts, in collaboration with my colleague, Professor Atish Kadioglu, who is the president of the Turkish Urology Association, who actually approached us, and he is also a member of our organization to put this program together. And we chose the topic of microTESE because this is one of the most important clinical procedure in the for the management of patients who have no sperm in the ejaculate. So this is a very complicated procedure. This is a procedure which is extremely important for surgical andrologists and also for those surgical andrologists who already are doing. We hope they will learn new things while going through this program that will allow them to improve their success rate. And for those who are not doing it and who want to learn, we hope this program will allow them to learn many new things that will perhaps give them the opportunity to practice this trade in the coming days. So the program includes these recorded presentations that we just talked about. Now Dr. Rupin Shah will begin the first presentation, followed by Professor Sophikidis from Greece, Dr. Arafa from Qatar, Dr. Israel from Mexico, and then Professor Atish will come over and give his presentation, followed by question and answer, a small session. Following that, the most interesting part of the program, which has never been done, is a case discussion. So each of the moderator, for example, we have 4 moderators, group 1 with Dr. Amarnath from Michigan in USA. Then we have Professor Poncho from Indonesia, from Jakarta, Baris Alte from Turkey, and Vineet from India. These are the heads of these groups, and they have very highly experienced clinicians who have been doing microsurgery for a long period of time and have distinguished themselves in this particular advanced surgical procedure. Professor Andrea, Dr. Vidi, Professor Giovanni, Professor Taha, Dr. Muratgul, Dr. Fotios, Professor Selahin, Professor Lukman, Dr. Tan, and then we have Dr. Manav, Professor Garmar, and Dr. Imad, all from different parts of the world. I mean, this is the first time such a program have been assembled, and we believe this will be one of the best program because each moderator and their panelists have worked very hard to create some clinical cases, and then what kinds of difficulties and problems that come will be questioned by their panelists, and they will answer those questions right on the screen. So you will be able to clear your doubts, all kinds of things that you perhaps would like to know, but have never been able to find their answers. So this is your opportunity today to learn from the experts. And it is not only for the novices, but also for the experts, because they will learn how best to do these procedures, because there is not one single way of doing these complex procedures. And then followed by the take-home message, which will be given by Professor Atish Kadioglu, and he will summarize all the proceedings, all the program, and that will be the end of the program. So I welcome you all to this very important program, and I will ask the IT team to begin the first presentation.
So thank you very much, Professor Agarwal. So we proceed with the first talk. Dr. Rupin Shah from India is going to talk on the detailed technique of microTESE procedure. Please run the video of Professor Shah.
And thank you for the honor of inviting me to speak at this special webinar on occasion of the 90th anniversary of the Turkish Urology Society. I will be focusing on the technical aspects of microdissection TESE. So let's start by looking at a video from Peter Schlegel himself one of the standard videos that he shares. There's a transverse incision. The testis is bivalved. The parenchyma is opened up. Hemostasis will be achieved with a microbipolar cautery, and then under magnification of around 20 times, the parenchyma will be explored and each lobule will be separated. You can see dissection along the lines of the vessels, while we inspect 4 tubules which are larger than the surroundings, and those larger tubules will be picked up and sent to the IVF lab. So that is the essence of the microTESE, and what we're going to do today is look at each technical step and try to point out practical little things that need to be kept in mind to achieve a good result. So I will be discussing the standard procedure as popularized by Schlegel, but I will add a few of my own practical experiences to it. So it'll be basically how I do it. And one thing which I do prior to a microTESE is a therapeutic SST mapping. SST stands for single seminiferous tubule biopsy. And we'll see it's a very interesting non-traumatic technique, which I've presented almost 20 years ago. So we have a long experience with it. In essence, we expose the testes, look for an avascular point in the tunica, puncture it with a 20 gauge needle. And then when you apply pressure through that puncture hole, you will see a single seminiferous tubule popping out. I do this under the microscope, but it could be done with loop magnification. That single loop is grasped with a microforceps and then pulled out of the testes. If the tissue or the tubule is thin and gelatinous, it will break and you stop the procedure. But if it's a good tubule, you can actually unravel a large, long segment, almost equal to an open biopsy, as you can see here. But there is no cut, no stitch, no bleeding. So it's a very atraumatic way of obtaining a biopsy from the testes. And because it is so atraumatic, it is possible to do multiple such biopsies over the entire surface. And this is the first step that we utilize when we have a good sized testes with healthy parenchyma. We will take between 20 to 30 surface mapping biopsies. Now, how does this compare with the microTESE? Of course, it's much safer than the microTESE because there's no cut, no stitch, no bleeding. The SST offers a better surface sampling as compared to microTESE. MicroTESE is, of course, more extensive, going into the entire testes. And thus, we view this as not competitive, but complementary and a preliminary step. If we find sperm by this method, then we stop here, having done something which is much less traumatic. In fact, the patient can go home in a couple of hours and go back to work the next day. And if we don't find sperm with this, we then proceed to the microTESE. So in those cases where the sperm are distributed throughout the testes, SST works well. Basically, these are men with maturation arrest or severe hypospermatogenesis, whereas the small atrophic testes where spermatogenesis is very focal will need microTESE. In small fibrotic testes, in fact, the SST technique does not work because when you try to pull out a tubule, nothing comes out. So now moving on to the classic microTESE, the first question is, should the incision be transverse or longitudinal? Transverse is preferred, and the reason for that is the way in which the blood vessels radiate from the hilum make a transverse incision more anatomical. And when you bivalve the testes through a transverse incision, you reach the hilum and you will see the blood vessels radiating out from the hilum in a radial manner, which makes it easy to separate the lobules. On occasion, I've done longitudinal because I was forced to due to a cut in the tunica. And usually the dissection is not as anatomical. So once we make the incision and achieve hemostasis from the tunical margin, one should inspect the surface without proceeding to bivalve the testes. And in many cases, this alone is enough to find some good tubules which will contain sperm like you saw here. And with a little bit of additional dissection, one would be able to identify enough tubules. You can see another one to the left. And these would yield enough sperm without having to do a very aggressive traumatic micro-TESE. Now, if we don't find sperm in the superficial dissection, then of course we have to split the testes. We hold the tunica with 2 mosquitoes. Now, it's important here to hold some parenchyma with the tunica so that when you split it open, the tunica splits open. It's important to avoid a protrusion, as you can see here, where almost half the parenchyma has separated from the tunica and come out. When this happens, the subtunical venous plexus will tend to bleed, and that is very difficult to control. So if you clamp the tunica with the parenchyma and then pull it open, you will split the parenchyma through the middle. If the testis is very fibrotic, sometimes one may have to cut through the parenchyma to create the plane of dissection and then use one's thumb to separate the parenchyma. Once the dissection is done, we start exploration, and the exploration is done by everting the parenchyma onto the finger. And you can see the vessels radiating out from the hilum. The dissection is done parallel to the vessels so that we do not damage the vessels, and progressively going deeper, separating the lobules and inspecting the tubules that are seen. One keeps a fixed magnification so that one gets a general idea of what the tubules look like. So here you can see atretic tubules. And as we are going deeper, one large single tubule pops out. And this is what would be biopsied. And we would keep on separating the parenchyma, going deeper, parallel to the vessels. The entire parenchyma is everted on the forefinger of the left hand, while the right hand does the dissection. So the steps of exploration are to put marker clamps in the tunica, usually at the upper border, lower border, and the middle, evert the parenchyma, and progressively go through the parenchyma till we see the tunica. The dissection is parallel to the vessels to separate the lobules. If there's an obvious bleeder, I burn it, but if there's minor oozing, I prefer to just apply pressure there while going elsewhere so that the hemostasis, coagulation is achieved, but without too much coagulation and damage to the tissue. I prefer a fixed high magnification so that one gets an impression of what the overall tubular pattern is. If you keep on changing the magnification, the tubules will look small at sometimes and large at sometimes. In some cases, you will see thin atretic tissue and then one large tubule, and that is very gratifying. In other cases, everything will look the same, particularly in cases of maturation arrest or in Sertoli only. And then we take random biopsies from the seemingly better tubule all across the testes. So here you can see that the parenchyma of the lower pole is everted on the forefinger. One mosquito is clamping the tunica and the parenchyma. Often there will be 2 more mosquitoes near the upper and lower corner. And when we finish that side, we will then hold the upper pole mosquito and rotate the testes so that the upper pole now rests upon the forefinger and the same dissection can continue. At the end of the dissection of the 2 hemispheres, of course, if you've got sperm, we stop earlier. We then inspect the entire parenchyma, achieving coagulation and also looking for some tubule that may suddenly pop up. And if it's a good-looking tubule, that can be picked up. We would take one small piece for histopathology, both to counsel the patient and look for any intratubular germ cell neoplasia. Now, closure can be tricky. Sometimes the dissection has been tidy and you can just put the parenchyma back and close the tunica. But especially for less experienced surgeons, or if the tissue has been very fibrotic, you may find that the parenchyma is badly shredded and you just can't put it back inside. So there are 2 approaches then. One is to just reconstitute 2/3 of the tunica without worrying about the parenchyma. And once the tunica is reconstituted, then there is space to push the parenchyma back in. Or one can take 3 or 4 interrupted sutures that approximates the tunica, and then it is very easy to control each independent segment. Closure could be done with a variety of materials. I prefer 5-O-proline because it is non-reactive. I used to use 6-O, but sometimes it broke, and if a continuous suture breaks, it can be very frustrating. I've seen Silber use 8-O interrupted sutures and other colleagues using absorbable. So all is fine. Closure is something, in fact, becomes easier as you get more experienced, and easy closure reflects your level of experience. If you've not got sperm on one side, we will usually explore the other side. And one important thing we do is we have the assistant apply constant pressure on the first testes while we are operating the other side. And this 15-20 minutes of pressure is very good for achieving hemostasis. And because we do that, we tend to prefer a separate incision. Otherwise, it's quite possible to explore the opposite testes from the same incision. If you're using the same incision, remember you're going through the septum and you will need to close that during closure. At the time of closure, I prefer to give a lidocaine, bupivacaine block, but that gives anesthesia for a couple of hours. And this pain-free initial period is very important in reassuring the patient and allowing for a quicker recovery. We close in layers, absorbable sutures for skin, and I find a tight pressure dressing applied with an elastic adhesive very helpful in minimizing hematoma. So to summarize, mTESE is the most efficient way to find sperm, but done incorrectly can be very traumatic. So it's very important to pay attention to fine technical points, make sure that one treats the parenchyma with respect, does not overcoagulate at the same time, avoid damage to the blood vessels. And in this way, we can give our patients the best chance of sperm retrieval. So once again, thank you very much for inviting me to be part of this wonderful meeting. We don't have questions at this point, but there will be a case discussion later.
Thank you very much, Professor Shah, for this excellent talk. So we are going to have the questions at the very end of this presentations, before the case discussions. And the second speaker is our dear friend, Professor Nicholas Sofikidis from Ioannina. He is chairman of SAO, European Section of Andrological Urology, and did significantly contribute to the field of male infertility over the last 30 years. So, Professor Sofikidis, can you run Professor Sofikidis' video, please?
I would like to thank very much Professor Agarwal and Professor Kadioglu, personal friends and worldwide known scientists in the field of male reproduction, for giving to me the opportunity today to participate in this seminar. Today, we are going to compare the ejaculated sperm ICSI with testicular sperm ICSI in subpopulations of infertile males. No conflict of interest. The post-testicular environment or epididymal or basal differential sperm transit can induce sperm DNA damage. Sperm DNA damage can occur in a minor degree in the lake and in a larger degree in the river. And within the testes, in this case rat testes, several studies have demonstrated lower degree of DNA integrity damage compared with epididymal lumen sperm DNA integrity damage. Epididymis is not the urinary bladder of the testis. Many important biochemical events occur in the epididymis, and a significant degree of sperm DNA damage in specific subpopulations of infertile males occur during epididymal passage. Even during the vasal deferential lumen passage. This is from the program of microsurgery in our laboratory. DNA damage in ejaculated sperm begins after spermatozoa are released from Sertoli cells and spermatozoa recovered from the testes show less damage than ejaculated spermatozoa. Greco reported higher pregnancy rates with ICSI techniques using testicular sperm rather than ejaculated sperm in couples with high levels of sperm DNA damage. It has been proposed that the poorer outcome with ejaculated sperm was a result of acquired DNA damage during transit through the epididymis. Why sperm DNA integrity damage is higher in semen than in testes? It relates to the susceptibility of spermatozoal chromatin to oxidative attack, particularly during epididymis transit. However, there are advantages of using ejaculated spermatozoa in severe oligozoospermic males. Testicular surgery is avoided and complications of testicular surgery are avoided. There are significant disadvantages of using ejaculated sperm in severe oligozoospermic males. Preparations of such samples requires prolonged preparation time. In other words, larger reactive oxygen species generation during centrifugation overall affect an impaired sperm motility and impaired ICSI outcome. Difficulties in freezing sperm of very low concentration are well known. An increased period of sperm transit through the male reproductive tract results in an increased nuclear DNA damage. Overall effect is a lower sperm motility and a lower ICSI outcome. A probable ovarian stimulation in these cases may be needless. In a nice old paper, reproductive outcomes of testicular sperm versus ejaculated sperm for ICSI techniques among males with high levels of DNA fragmentation in semen were compared. This was a nice systematic review and meta-analysis. The conclusions of this study were that testicular spermatozoa have lower levels of sperm DNA fragmentation than ejaculated spermatozoa, and TESE for males with high post-testicular sperm DNA fragmentation improves reproductive outcomes compared with ejaculated ICSI. TESE should be preserved for men with substantial sperm DNA fragmentation undergoing assisted reproductive technology, particularly those experiencing repeated ICSI failures, and when measures and trials to correct underlying factors causing sperm DNA fragmentation have failed. In an interesting study, was concluded that when high DNA fragmentation is detected, ICSI using testicular spermatozoa seems an effective option, particularly for those with repeated assisted reproductive technology failure in terms of pregnancies and miscarriage, even though conventional sperm parameters are within normal range as concluded by the authors of this study. Because of the missing solid evidence from randomized studies, it may not be suggested to perform routinely TESE in oligoasthenoteratozoospermic patients with high DFI or men with cryptozoospermia. According to the guidelines of European Academy of Andrology, in cases of 2 or more ejaculated sperm ICSI failure with uncorrectable high DFI, TESE and use of testicular sperm for ICSI can be considered low quality evidence. In case of cryptozoospermia, based on experience showing reduced ICSI success rates when using spermatozoa from the ejaculate, use of spermatozoa from the lake, from the TESE material was reported in a retrospective study to result in a higher clinical pregnancy rate and a higher live birth rate. According to the guidelines of our mother society, according to the European Association of Urology, testicular sperm is reported to have lower levels of sperm DFI when compared to ejaculated sperm. Couples with elevated DNA fragmentation may have a benefit from the combination of testicular sperm extraction and ICSI. This approach is called TESE-ICSI, which may not overcome infertility when applied to an unselected population of infertile men with untested DFI values. It means to go for TESE-ICSI in these men, we need to know high DFI. Further evidence is needed to support this practice in the routine clinical settings. I would like to thank very much Professor Agarwal and his colleagues and all of my friends in the Turkish Urological Association and Professor Kadioglu for giving to me the opportunity to share with you my knowledge and my experience on this issue. Thank you very much.
Thank you very much, Professor Sophikidis. It was a pleasure getting your feedback on a very highly debated and very important topic of the use of testicular sperm in cases of high sperm DNA fragmentation. Thank you for sharing your important observation. Next, we want to move to the third speaker. And third speaker is Professor Mohammad Arafa from Qatar. He's an andrologist with many years of experience in this field. And he's a very talented microsurgeon. He is going to talk today on the hormonal treatment after failed micro-TC, and he will tell us if it is justified. So Dr. Arafa is going to come through his recorded presentation. Thank you.
Hello, everyone. First of all, I want to thank the organizing committee for giving me the opportunity to be here among colleagues and friends and to share with you this very interesting presentation about the hormonal therapy after failed micro-TC and whether it is justified or not. First, let's start with some physiology about the hormonal control of spermatogenesis. As you all know, gonadotropin-releasing hormone is released from the hypothalamus to stimulate the gonadotropes in the anterior pituitary to produce FSH and LH. The FSH works on the Sertoli cell, where it leads to increase in the number of spermatogonia and spermatocytes, stimulation of proliferation of Sertoli cell, whether in prenatal or prepubertal periods, and stimulate the Sertoli cell to produce sex hormone-bound globin, which lead to maintenance of a high intertesticular testosterone level needed for spermatogenesis. On the other hand, LH will work in the Leydig cells to produce testosterone, which in turn will stimulate the later stages of spermatogenesis and stimulate Sertoli cell tight junctions, so keeping the internal environment of the testis optimum for spermatogenesis. So as we see, FSH and LH work synergistically together. Testosterone is then changed to estradiol, which in turn will exert negative feedback effect on the hypothalamus and the anterior pituitary, keeping the FSH and LH levels within the normal physiological levels. Azoospermia, which is the absence of sperm in the ejaculate, occurs in 1% of the general man population and up to 15% of infertile men. Non-obstructive azoospermia is the severest form of male infertility and of azoospermia, which is due to impairment of spermatogenesis. It comprises 10% of infertile men and reaches up to 60% of all azoospermia cases. For these cases, surgical sperm retrieval is the only hope to get sperm to be used for fertilization using assisted reproductive techniques. When we come to the history, in 1985, this was the first report about pregnancy with conventional IVF using epididymal sperm. Then after this, in the early 90s, ICSI was introduced, and the first case of pregnancy using ICSI with testicular sperm in obstructive azoospermia was reported in 1992. But it was not until 1995 when this technique was reported to be successful in men with non-obstructive azoospermia, which before this had only two choices for fertility, either to go for donor sperm and IVF or for adoption. Nowadays, we can confidently say that surgical sperm retrieval is positive in up to 60% of non-obstructive azoospermia cases, so giving much hope for these patients. A lot of studies have been done since then to check the predictors of successful sperm retrieval, surgical sperm retrieval, including hormonal level like FSH or testosterone, testicular size, testicular histopathology, age. And I can say that apart from testicular histopathology, all other predictors are controversial and their role is doubtful. Similarly, scientists and doctors have searched the methods to enhance surgical sperm retrieval. This include hormonal stimulation, varicocectomy prior to surgical sperm retrieval, changing techniques with the introduction of microsurgery, which have greatly improved the surgical sperm retrieval up to the 60% that we are talking about now. There are other new methods that are experimental or just newly added, but this is out of the scope of the current presentation. Let's concentrate on the hormonal therapy in non-obstructive azoospermia cases. The first question will come to your mind. In these cases, the FSH and LH are already high. So what will be the benefit of adding more FSH and LH to these patients? There are multiple theories. The first one is that the constant elevation of FSH in these patients will lead to downregulation of FSH receptor in Sertoli cells. So when we give HCG, this will lead to increase of testosterone, exerting negative feedback on the pituitary and the hypothalamus, leading to decreased endogenous FSH, which will hypothetically reset FSH receptors. And then when you introduce exogenous FSH, this will lead to induction of spermatogenesis and increase in the Sertoli cell count. And as you know, each Sertoli cell can accommodate or can maintain a certain number of spermogenic cells. When we increase their numbers of the Sertoli cell, then we can increase the spermatogenesis. The second theory is that intratesticular testosterone is decreased in non-obstructive azoospermia cases. As you know, the intratesticular testosterone is 50 to 100% more than the serum level, and it is needed for spermatogenesis. So this decrease in non-obstructive azoospermia shows that there is disturbed intratesticular hormonal milieu in addition to the disturbed spermatogenesis. Therefore, restoration of Leydig cell function through hyperactivation by high-dose exogenous HCG can lead to elevation of intratesticular testosterone and thus stimulation of spermatogenesis. A third theory was that effective HCG stimulation will also lead to the secretion of several endothelial growth factor-like substances from the Leydig cells, which in turn will stimulate spermatogonial DNA synthesis and spermatogenesis. The last theory is that men with early maturation arrest have lower androgen receptor index than those with late maturation arrest. These scientists hypothesize that men with late maturation arrest are the only ones who will benefit from the hormonal therapy at that level. What about the guidelines? The AOA and the ASRM said that we have to counsel the patient that there is limited data supporting the use of hormonal therapy before TACE. EAU said that there is no conclusive recommendation and should not be used routinely before TACE. And the Canadian Urological Association were more diligent and said that it is discouraged to use hormonal therapy for cases of azoospermia. Now to our question. Will we use hormonal therapy after failed micro-TACE? Let's see the evidence from the literature. I have found 4 studies. The first one, 2012, in Japan by Shirashi et al. He studied 48 men with failed micro-TACE. 28 men agreed to take the treatment protocol, and 20 men refused and were considered as control groups. The treatment regimen included HCG 5000 international unit 3 times per week for 3 months, then assessment of FSH. If it decreases, they will add FSH 150 international unit 3 times per week for 2 months and repeat the micro-TACE. The results were very promising. They found sperm in 6 out of the 28 cases. 4 of them were hypospermatogenesis and 2 with early maturation arrest, surprisingly. While in the control group, sperm couldn't be retrieved from any of the 20 patients. The second one was also from Japan, but from Shino et al., where they studied 20 men with failed micro-TACE, given the treatment, and 18 controls which were obstructive azoospermia. They followed the same treatment regimen as Shirashi et al., and they found sperm retrieved from 3 out of the 20 patients. 2 of them were using HCG and FSH, and 1 was using HCG alone. They also found that in the obstructive azoospermia group, FSH and the H were significantly lower, and testicular volume and testosterone level were significantly higher than those with non-obstructive azoospermia, which is expected. The third one was again from Shirashi et al., but this one was a multi-center study. They studied 21 men with failed micro-TACE, 13 were sertolizumab only, 1 hypospermatogenesis, and 7 maturation arrest. They used a different regimen here. They gave HCG 5000 international unit 3 times per week for 1 month only. Then added FSH 150 international unit 3 times per week for 3 months and repeated micro-TACE. Sperm could be successfully retrieved in 2 out of the 21 cases, 1 of them with hypospermatogenesis, 1 with late maturation arrest, and none from the Sertoli cell and early maturation arrest groups. The last one was from Egypt, by Dr. Amir et al., where they studied 40 men with failed micro-TACE. 20 agreed to take pre-treatment before the next micro-TACE, and 20 refused and were included as controls. They used a very different regimen of treatment. They did testosterone downregulation using testosterone enanthate to 250 international units per week for 1 month, followed by HCG 5000 international units once per week, FSH 150 international unit 3 times per week for 3 months, then repeated micro-TACE. They reported that they found sperm in 2 out of the 20 cases who received the treatment regimen, and both of them had mixed histopathology, while none was from the control group. It's worth saying that they stated that these 2 cases where they found sperm, the previous micro-TACE was not done in the same center, and was done probably using loop magnification instead of surgical microscope, which could affect the results. So let's ask ourselves the question: will we give or will not give hormonal therapy before testosterone, before failed micro-TACE for the next micro-TACE? There is no enough evidence to support hormonal therapy after failed micro-TACE. However, let's think about these patients. What other choices do they have? They did micro-TACE and it was negative, and we want as much as possible to increase their chances of finding sperm. So there is still a chance to use the hormonal therapy before the next micro-TACE in some patients after proper counseling. We should honestly tell them about the results and the prognosis, and they can choose. The hormonal therapy is not without side effects. There are minor side effects like acne, body weight increase, and there are severe side effects like hypercoagulable state with possibility of DVT and even pulmonary embolism. Plus the cost of the treatment, which will add to the cost of the microTESE and ICSI later on. Thank you very much.
Thank you very much, Professor Arafa, for your very nice presentation on hormonal treatment for failed microTESE. I think the evidence is kind of weak, and I think this is an area which requires a lot more clarity. But I would like to move on to our next speaker, who was supposed to be the first one, had some technical problem, but now it is solved. It is Professor Atish Kadioglu. Atish is a full professor of andrology in Istanbul Medical College for a number of years, almost for more than 3 decades. And he is virtually considered as the father of andrology, who has developed the field of andrology, not only in Turkey, but all over Europe. And he is going to be speaking today on the testicular anatomy with an emphasis on microTESE. Atish, please, actually, we should have his video now.
Thank you very much, Professor Agarwal, for the collaboration between Turkish Association of Urology and Global Andrology Forum, and also for the talk on testicular anatomy with an emphasis on microTESE. The testis in young healthy male has a volume of approximately 20 cc, between 15 and 25 cc's, and the longitudinal length is between 4.5 to 5 centimeters. A capsule is made of 3 distinct layers surrounds the parenchyma of the testis, the tunica vaginalis, tunica albuginea, and tunica vasculosa. What we also know is the testis is divided into lobules. There are approximately 250 lobules in each testis, and one lobule is containing 1, 2, 3 convoluted seminifer tubules. So total 750 seminifer tubules exist in one testis. And the length of the seminifer tubules is about 30 to 80 centimeter. And if we, take the whole length of the tuberous seminifery into consideration, then the total length equals to 360 meters for testis and 720 meters for per man. If we look to the vascular anatomy of the testis receive the arterial blood flow mainly from the testicular arteries, cremastic arteries, and differential arteries, the artery of the vas deferens. And as we all know, the testicular artery arises from the abdominal aorta just below the renal artery. And here you can see the, testicular artery arising from aorta, and at the level of the caput epididymis, it takes the shape of a coil and then runs posterior of the testicles to the inferior pole, and then ascends onto the anterior surface. And in between, there are some branches from this capsular artery to the rete testis. The second artery is the differential artery, and it also runs toward the lower pole of the testis and make anastomosis between the testicular artery. The third one is the cremasteric artery, which is the tiniest one, and it runs again posterolateral surface of the testis, and there are also anastomosis between the cremasteric artery, differential artery, and testicular artery. The cremasteric artery arises from the inferior epigastric artery, and again, there are anastomosis at the lower pole of the testicles between the testicular artery and cremasteric artery. Deferential artery, on the other hand, arose from the inferior vesical artery. Again, vasal branches anastomosed freely with branches of the testicular artery along the mediastinum testis and close the lower pole of the testis. This is, I think, a very important slide, showing the detailed interlobular anatomy. So this is the, tunica vasculosa. From the tunica vasculosa, from the anterior surface of the testis, the tunical, between the tunical septa, the artery went toward the rete testis, and this is called centipedal artery, and at the level of the rete testis, the centipedal artery turns back and goes again toward the cortex, toward the tunica albuginea. This is called recurrent arteries, and at the level of the tunica albuginea, it is called segmental arteries. So the centipedal arteries, the recurrent arteries, and segmental arteries. If we cut at this level the recurrent artery, then the whole lobule, blood flow is compromised. So care should be taken during microtese at the level of the rete testis, deep after having incised the tunica albuginea, not to compromise these recurrent arteries. In this, study by Wolfgang Wagner and Associates some time ago, 2018, the intratesticular peak testicular velocity correlation with sperm retrieval was investigated. And what the authors have found is there is no correlation between intratesticular peak testicular velocity and sperm retrieval rate. Here you can see peak testicular velocity in TESE positive and TESE negative cases. There is no statistical significance between the velocity of the testicular arteries. The analysis study was conducted by our dear friend Bilal Gümüş and Associates, where they investigated the surface area of the longitudinal incision and compared this with the horizontal incision. And the surface area after the longitudinal incision was found 1/3 larger compared to the horizontal incision. In another study by Ishioka and Associates, three-dimensional simulation analysis of the microdissection technique was compared. And the longitudinal incision with transverse slicing has been found with higher TESE positive rates, theoretically, in the simulation by 29 to 45% compared to other incision types. So after this publication at Istanbul Medical School, we also changed our policy in terms of the type of incision. We perform a longitudinal incision and transverse slicing, and then collect the 75 tuberous large and white looking 75 tuberous. In conclusion, the tunica albuginea incision should be performed by paying attention to the arrangement of the lobules when performing microtese. The lobules are, arranged like a book. So we need to open a book and try to find sperm in the appropriate 75 tubuli. And during microtese, of course, the distribution of the intratesticular artery anatomy should be taken into consideration to avoid, vascular complications. Thank you very much, and I am ready to answer if there are questions any.
Thank you very much. Thank you very much, Professor Atesh, for your wonderful presentation. And I think this explains the complexity of doing microtese. Just to look at the vascular architecture of testis, I think it is very advanced and complicated, and if the surgeon is not fully aware of these finer details, they are surely going to make mistakes and create complications. So I believe that it is extremely valuable that these talks are part of this program. Thank you very much. I
So,
just wanted to mention that there are many people who are contacting us and texting us that they want to join the program, but we are not able to accept them because they have to pre-register. And once the program is started, registration is not allowed and they are not able to enter. So our apologies to those who could not register earlier and are trying to join. They will have to wait until this program is actually recorded and it will be posted online by us. So for now, I think we move to the next speaker. Our next speaker and the last speaker of this first session is my good friend Dr. Israel Maldonado from Mexico. And Israel is a very highly talented embryologist. He will be speaking on the embryologist role during the microtesi. And this is very important because getting the sperm, which is extremely complicated, is the job of a trained microsurgeon. But that is really where their role finishes. And then I think there is a team which has to come into the picture and which involves really highly dedicated and trained embryologists and their colleagues because the sperm will have to be actually extracted from the testicular tissue. They have to be released, they have to be saved. If it is a fresh procedure, then they have to be prepared for use because testicular sperm are generally terrible. They have no motility, they have nothing. So to really activate those sperm requires special skills, and really I think these are extremely valuable practical things that most people are not aware of. How to really resuscitate like a dead patient. This sperm are dead pretty much. As you look at them, there is nothing going on in this sperm. So I encourage my colleague Dr. Israel's presentation can begin now. Thank you.
Good morning, everyone. I'd like to thank the organizing committee for giving me the opportunity to present this lecture today. My today's topic is embryologist's role during micro-TC. During this lecture, we are going to cover the following learning objectives. We are going to describe the recommended strategies to manage testicular tissue from micro-TC prior an IVF procedure, understand the importance of the accuracy of sperm processing techniques that may affect the outcome of micro-TC, how to avoid inter- and intra-laboratory variability during testicular sperm processing, brief description of the correct management of testicular sperm in non-obstructive azoospermic patients to improve clinical outcomes, and finally, the conclusion. The success of an IVF cycle involving micro-TC procedure could be affected by both the surgeon's skill and the embryologist's experience on the management of testicular sperm in the IVF laboratory. The most common methods to process the testicular tissue in non-obstructive azoospermic patients is the following. Before micro-TC procedure, it is necessary to prepare several sterile Eppendorf vials with 200 microliters of HIPIS medium supplemented with 5% of serum albumin. The surgeon will place the surgically retrieved tissue in a vial with the buffer medium, so the embryologist has to consider that the surgeon may retrieve multiple samples. The mechanical disruption of the testicular tissue during laboratory processing is considered the first step to find sperm cells with a contest pistol to mincing the testicular tissue as it is shown in this protocol. But also mechanical disruption of the testicular tissue can be performed using different techniques such as vortexing, or by pipetting several testicular tissue a few times to allow sperm to exit the seminiferous tubules. After mechanical testicular tissue disruption, a small 10 microliter volume of each Eppendorf vial should be aspirated from the minced sample and placed on a plain glass slide, and a cover slip is placed on top. Samples are examined under the inverted microscope for the presence of sperm. It is highly recommended to include at least 2 embryologists during the laboratory processing after micro-TC, where one will dissect the retrieved sperm while the other one will check the presence of sperm to provide a quick feedback to the surgeon to either continue searching for more promising tubules or terminate the micro-TC procedure. If at least one spermatozoon per slide is visualized under inverted microscope, the sperm retrieval can be considered successful. If no sperm are identified in any of the samples examined or rare sperm have been identified, then we should proceed with the enzymatic digestion of the testicular tissue. It is mandatory not to stop at mechanical mincing if sperm are not visible in the sample under the microscope. The use of a pretreatment with erythrocyte lysine buffer is highly recommended, because another important challenge for the embryologist is to find sperm cells among the excessive presence of red blood cells in the sample. This can make difficult the inspection of sperm under the microscope, especially if the retrieved sperm are immotile. So, to overcome this problem, we need to follow the next protocol. The testicular sperm brought from the operation room is kept in the incubator at 37 degrees. Then, to process with the sperm sample, we need to add an equal volume of pre-warmed erythrocyte lysine buffer to the tissue sample and incubate the sample for 5 minutes at 37 degrees Celsius. After this time, we need to add 4 ml of HIPPIS medium and also we need to centrifuge the sample at 1800 Gs for 5 minutes. Remove the supernatant and add an equal volume of HIPPIS medium to the tissue pellet. Then mix the tissue pellet with HIPPIS medium using a 1 ml pipette to resuspend the pellet and immediately proceed with the enzymatic digestion. For the preparation of the collagenase DNase mixture for the enzymatic digestion of the testicular tissue, the protocol is the following. Take 120 ml of HIPPIS medium supplemented with 5% of HSA and add 6 milligrams of the DNase from Sigma Aldrich and mix very well. Then transfer 10 ml of this solution to a 50 milligram bottle of type 4 collagenase, also from Sigma Aldrich. It is important to mention that the application of enzymatic treatment to the testicular tissue is still controversial, especially because the fertilization rate is significantly affected by using sperm after enzymatic digestion. But on the other hand, the digestion of the testicular tissue may lead to successful sperm recovery in several men with non-obstructive azoospermia, whose tissues failed to demonstrate any sperm after classical mechanical crushing. So, to continue with the preparation of the collagenase DNase mixture, it is important to filter the solution through a 0.2 microns filter into sterile cryovials in aliquots of 1 ml and freeze these aliquots immediately at minus 20 degrees Celsius. For the enzymatic digestion of testicular tissue, I can say that the application of the enzymatic digestion to the testicular tissue will facilitate to extract any testicular sperm from the testicular tissue, reducing the duration of manual sperm searching under microscope and diminishing errors by embryologist exhaustion. For this purpose, the recommended protocol is the following. The enzyme solution already prepared is thawed in a 30 degrees Celsius water bath for 5 minutes. Add the enzyme solution at 1:1 ratio to the tissue suspension. Incubate the enzyme and tissue suspension at 37 degrees Celsius during 1 hour, agitating the tubes every 10 to 15 minutes to facilitate the tissue digestion. After incubation, the digested tissue solution should be gently centrifuged at 50 Gs for 5 minutes in order to remove all the residual not digested pieces or the debris. Finally, transfer all the supernatant to a 15 ml conical tube, taking care not to discard the supernatant because this contains the digested tissue. Remove the enzyme from the digested tissue by adding an equal amount of sperm wash medium to stop the digestion process. Then centrifuge are 1800 Gs for 5 minutes. The supernatant cell suspension should be washed twice with fresh buffered medium. And finally, examine the small aliquot of the sample for the presence of sperm. Then the resuspended pellet is used to prepare the microdroplets for the ICSI procedure. One of the biggest concerns the embryologists have is to introduce immotile sperm or not viable sperm into the oocyte. The use of pentoxifylline is useful in order to increase or improve the motility of the sperm. In this article, you can see that the fertilization rate and the number of viable embryos after the IVF procedure are significantly increased. If the pentoxifylline fails to improve or to detect the viable sperm, so there are different techniques that we can use in order to select the viable sperm. For example, Hall's test, mechanical technique using the micropipette to activate or to move the sperm tail, and also the use of laser. So in order to make easier the identification of the sperm cells in the media or in the middle of the cells of the tissue, so it is important to use the technology. In this case, artificial intelligence is going to help us to increase in a much easier way and reducing the time consuming by the embryologist during the sperm searching. So the use of fresh or frozen sperm from non-obstructive azoospermic patients are going to produce the same results when we compare the clinical pregnancy and live rate when we used fresh or frozen sperm. So for the concluding marks, we can say that the use of the correct protocol by the embryologist is an essential part during the process of testicular sperm that together with the clinician share the same final goal, the success of a procedure. To establish a training program for young embryologists is mandatory to be able to manipulate difficult cases of micro-TC. The introduction of a quality control system during laboratory processing after micro-TC to check the performance of the procedure and staff according to the key performance indicator is also recommended. And finally, the experience is essential to avoid or decrease the damage of the cells during tissue while also working toward framing outcomes in ways which are the most pertinent for patients and practicing clinicians. Thank you so much.
So thank you very much for this excellent talk, Dr. Maldonado from Mexico. So we have 10 minutes for the questions and answers. There are several questions, coming from the floor and also from the attendees. The first question is to Dr. Mohamed Arafa. The question is, Professor Arafa, do you consider hormonal manipulation in patients who are eugonadotropic with non-obstructive azoospermia, or just, do the hormonal therapy in patients with low testosterone level?
Hello, everyone. Up to now, as we said, there is no evidence or clear evidence regarding the hormonal treatment in non-obstructive azoospermia cases. Of course, the best results will be in those with hypogonadotrophic hypogonadism, which is a straightforward case. But in cases with hypergonadotrophic, either hypogonadism or eugonadism, the results are still not clear. But as I said, these patients are already one of the severest cases, and we want to give them the best chances. So we go for stimulation, hormonal stimulation before testicular sperm retrieval, and we counsel the patient, and we're telling them that the evidence is low, but we are trying to give them the best chances, and we tell them about the side effects so they will know what they are going through.
Okay, thank you. The second question goes to Professor Shah. When do you prefer horizontal and vertical incision? Actually, they ask why valve horizontally compared to vertical incision. Do you have any idea on that, Professor Shah?
I think we could possibly both answer this question, since you also have some very interesting anatomical data. I prefer a transverse bivalving because I find that takes me straight to the hilum, from where I can see the vessels radiating outwards, and it makes the dissection more anatomical. It is a little difficult reaching the upper and lower pole through a transverse incision, but the vascularity is better preserved. I think you showed an alternative approach with a longitudinal incision and then transverse slicing. So perhaps you could comment on that.
Okay, thank you. The next question is to Professor Sofikidis. And the question is, when do you do TESE or micro-TESE after ICSI failure? How many cycles of ICSI should be performed in order to go to the testicle to harvest sperm? Is Professor Sofikidis with us?
Yes, thank you very much, and congratulations, Professor Kadioglu and Professor Agarwal. Actually, according to the European Academy of Andrology guidelines, in cases of severe oligoasthenoteratozoospermia, 2 ICSI failures, repeated implantation failures justify to go for TESE.
Okay. So there is no other questions at this stage. I'd like to thank to the presenters there is also some questions from the floor from, Antalya. We are here, Antalya. Please, we have time for 2 questions. Activate the microphone first, please. Yes.
I want to ask a question to our embryologist panelist.
Whom are you going to direct your question?
Maldonado.
So, okay. To Professor Maldonado, embryologist, yes.
At the time of the TESE surgery, at one point comes an embryologist say to urologist, it's enough, you can finish. How you decide this?
When to stop? So did you hear the question, Professor Maldonado?
Yes, I hear.
So at what stage should the embryologist, stop the surgeon to continue to collect sperm, to collect seminiferous tubuli from the testicle? Is there any time limit, or how many pieces of the, micro-TESE should be performed, taken out? So is there any limit? I mean, what is the cutoff, is the question from the floor.
For example, in our case, we perform the micro-TESE procedure the same day of the egg collection. So first of all, we check how many oocytes we have from the patient, and after this, we decide, according to the sample of the tissue and the number of sperm retrieved, if one sample or two different biopsies are enough in order to have the enough number of sperm to inseminate the oocytes. This is the main parameter we take into account in order to decide if one micro-TESE procedure should be finished or we need to continue.
And second question.
I just want to add one point here, Atish, if I may.
Yes.
What the question was, I mean, it can be both ways. Dr. Israel presented one side that there are some sperm, and based on that, he can consider when to stop. But in other situations, when the surgeon has taken out, let's say about 10, 12 different pieces of testicular tissue from different regions, and under the microscope, they have been examined very, very thoroughly under the dissecting microscope, and we are not able to find any kind of sperm under any circumstances. That after thorough examination by at least two embryologists and andrologists, we will decide and tell that there is no possibility of finding anything. So I think we will probably call it a day. So at least from our side, that will be the time when we will say that there are no sperm that we could find. Of course, they can look it up under the operating microscope when they are performing the procedure to see if there is any kind of fluid coming out from the seminiferous tubule when they are trying to look for the sperm. But from the lab perspective, if we are not able to find anything, then that's after 8 or 10 tissue, we'll stop it.
Okay. The next question is for Dr. Arafa. Do you recommend for patients with Klinefelter syndrome and low testosterone hormonal manipulation? Klinefelter syndrome, Professor Arafa.
Thank you for the question. Actually, the Klinefelter patients are a good subset for hormonal stimulation before going for microsurgical sperm retrieval. There are a lot of studies that showed that prior to micro-TESE, hormonal stimulation, especially with aromatase inhibitor like anastrozole, and sometimes adding to it HCG, greatly improves the chances of sperm retrieval in this subset of patients. It's worth saying that these patients are having very small testes, and the first micro-TESE will give them the best chances to find sperm. And repeating the micro-TESE in these small testes is somewhat challenging. So to give them the best chances in the first micro-TESE, it is advisable, although there is no yet recommendations for it, but there is a good number of studies advising giving anastrozole before going for micro-TESE in patients with Klinefelter syndrome.
Okay, with this answer, the question Q&A part is concluded. Thank you very much. So at this stage, I think we have more than 900 attendees registered for this webinar. And also here in this room, there are approximately 100 friends, colleagues from Turkey who are attending live this session. So it is really a success in terms of the academic program and also from the number of attendees point of view. So we proceed with the case discussions. We have a total 4 cases, 1 moderator for each and 3, discussants. The first moderator is Dr. Amarnath Rampatla and Professor Salonia, our dear friend from Milano. San Rafael University, and Vidi Make from Indonesia, and Giovanni Colpi from Italy, working now in Switzerland, will be panelists. Please go ahead for the first case, please.
Thank you. Can you guys hear me okay?
Yes, yes.
I'm gonna share my slides here. Okay, can you see my slides?
Yes, we can.
So thank you. I want to just take a minute and congratulate all the organizers and speakers on an excellent conference so far. So I'm tasked to moderate our first case discussion, and we're going to discuss a case of a repeat micro-TESE. And I was able to query some of our panelists beforehand on some of the questions that I'd like to discuss. And what I'd like to really focus on is the differences in answers between the panelists, and and this will sort of highlight that with these complex cases, we may not know what the best answer is, and there are different treatment approaches. And with further research and further studies, this is how we're going to propel the field forward and come up with new guidelines that we can all use to have better outcomes. So I'd like to welcome our panelists for today, Professor Salonia from Italy, Dr. Atmoko from Indonesia, and Professor Colpi from Switzerland. So our case is a 33-year-old male who presents for a second opinion regarding his azoospermia. He and his wife have been trying to conceive for the past few years. His wife is healthy, normal menstrual cycles, normal reproductive evaluation. He has undergone 2 previous semen analysis, which showed normal volume azoospermia, and hormonal evaluation has shown a testosterone level of 290, FSH 21, LH6, and estradiol 22. He has normal genetic evaluation, normal karyotype, and no Y chromosome microdeletion that has been detected. So he underwent a previous bilateral micro-TESE a few months ago, and this did not result in any sperm that were retrieved. There was a testicular biopsy sent for histopathology at that time that showed Sertoli cell-only syndrome. On your examination, he has a normal phallus. Both testicles are descended, and he has a 12 cc testicle on the right side, 10 cc's on the left side, and no palpable varicoceles that are detected. So my first question to the panelists were, how would you counsel him regarding his chances of having a successful sperm retrieval on a repeat micro-TESE procedure? And one of our panelists answered that there needs to be detailed assessment of the previous micro-TESE procedure, including the urologist and embryologist experience, the technique used, the magnification that was used during the surgery, and the duration of the surgery. Previous literature shows that a repeat micro-TESE can be successful anywhere from 0 to 11% in some case series, and others showing up to about a 40% chance of success. Another panelist said the success of a repeat micro-TESE, or a success of a micro-TESE in the setting of Sertoli cell-only syndrome is about 20 to 30%, and a repeat micro-TESE in the setting is about 10%. So with this, I'd like to invite Professor Salonia for your comments. What do you think about this patient's chances of a successful micro-TESE repeat?
Yeah, from a very practical point of view, we do have 3 data which, to me, should be really considered. The first one is that we must consider every single couple coming to the office and seeking medical help considering both members of the couple, since that lady had an AMH, which is 1.5, if I'm not wrong, and 1.5 is very close to 1, although it is normal. But according to most of our guidelines data, we should consider that one as an issue. The second issue is that we do not have data enough to say that a repeated TESE is the right way to proceed with, since according to what has been already presented, from the pathological point of view, from the histological point of view, Sertoli cell-only syndrome, unfortunately speaking, is the less positive outcome we may have. Indeed, if you get a look to the data which have been published up to now, there are data suggesting that hyperspermatogenesis could be helpful. There are data with maturation arrest, which could be helpful, but the lowest finding in terms of positive outcome are associated with Sertoli cell-only syndrome. This is the case for me, and therefore I will update our patients dealing with the concept that fortunately or unfortunately, it does have FSH close to 21, and the FSH per se is not sufficient to say this is a positive versus negative outcome, then therefore it is an issue. But at the very same time, it does have low testosterone and quite high estradiol, and the ratio is important. We do not have inhibin B and AMH, and we will discuss about that later on. And finally, we do have SHOS, which is Sertoli cell-only syndrome, and therefore having this kind of data in our hands is very important.
Thank you. Professor Colpi, anything else to add on this scenario? I don't think we can hear you, Professor Colpi.
Not at all.
Okay, do you hear me?
Yes, we can hear you now.
Okay, sorry. Well, I must say that what was told by Professor Salonia is absolutely right, but we must take into consideration that if the histological examination had been a hypospermatogenesis, probably the microTESE was not unsuccessful, the first microTESE. And really, we know, at least according to our personal experience, that the histologic examination of the diagnosis of Sertoli cell-only syndrome is absolutely the most frequent case in case of non-fatty azoospermia. Well, I must say that according to my long experience, really the success rate in case of Sertoli cell-only syndrome is really about 33% in the first microTESE, not in the repeat microTESE clearly. But in fact, just for this reason, I specified that my counsel depends mainly on a detailed assessment of all the steps of the previous microTESE, because according to my experience, a lot of patients coming to my observation with a previous microTESE, when you examine exactly all the steps, you realize that very often, at least two out of 3 cases, the microTESE was not performed according to the top rules. Okay, that is either the surgeon was not extremely expert, or mainly the time of the operation, the duration of the operation was very low. Okay, and so may suggest that microTESE was not performed really in according to the best procedure technique. Okay, and so surely we have in this case a low testosterone. We don't know, slightly low testosterone. We don't know, there is no evidence that increasing the testosterone, this will mean absolutely a higher success rate. But in any case, I suggested to perform a stimulation of the Leydig cell and to increase the testosterone level.
Perfect. Thank you. So let's move on. So the next question I had for the panelists is, how long would you wait after failed micro-TESE to do a repeat? And I think we can all agree on the waiting period should be a minimum of 3 months and at least usually 6 months in most cases. Dr. Admoko, is there any reason to do this before 3 months in any scenario?
Yeah, thank you, Dr. Amar. So I personally usually wait for at least 6 months before repeating the micro-TESE, as we have to wait for the recovery of the limited sperm production. And although the new evidence show that the 3 months is possible, a longer period is preferable and show a better chance of the sperm retrieval. So I think the patient's wife has a border low normal AMH and despite a relatively young age. So I would prefer to not to delay it for too long. So maybe 12 months is at the maximum.
Perfect. Thank you. So let's move on to the next, because I think there are some discrepancies here on what the panelists think. So is there a role for testicular mapping prior to a repeat micro-TESE? Professor Salonia, what are your thoughts?
I'm completely against, if I may. According to my role as the chairman of the European Society for, guidelines panel on sexual and reproductive health, we clearly outline that the FNA does not have any role both in the pre-setting and in order to investigate the real presence of sperm. So I'm completely against, if I may.
Okay. Dr. Admoko, you said that you've had some success with FNA mapping. Can you please share your thoughts with us?
Yeah, thank you, Dr. Amar, and also Professor Salonia. So actually in our center led by the Professor Poncho, we had done several cases with the FNA mapping in cases of the failed mTESE and have successfully found the sperm. And similarly, the research by the Jarvis et al. Show that the subgroup of the men with no spermatozoa on a prior mTESE and the FNA mapping revealed the spermatozoa almost 1/3 of cases, including those with the Sertoli cell-only Sersin syndrome histology. However, with the possibility of the damaging TESEs, I agree with you. It should be well informed to the patient for the benefit and also the risk.
Thank you. Thank you for your comments. So let's move on. In terms of technical strategies, what would you employ to help lead to successful sperm retrieval? And these could include avoiding exposure to toxic chemicals, scrotal heat, starting hormonal therapy, and considering antioxidants. So Professor Kolpi, in which situation would you consider hormonal therapy and antioxidants? We've heard a little bit about this from Dr. Arafa, but I'm curious to get your thoughts.
Antioxidant may be useful, although there is not enough evidence about that. In this case, it is better to check the kind of job of this patient, and if you realize that he can be exposed to some risk, in this case, antioxidant may be useful. About testosterone, I regularly prefer to stimulate the testosterone level above 350 nanogram per DL. Okay, this is my position.
Thank you. Dr. Admoko, can you elaborate a little bit on a sperm heat map and how you focus on the periphery of the testicles rather than central locations?
Yeah, so basically there are no specific technical strategies that I employ in for my surgery. But however, I always use the bilateral exploration with the micro-TESE whenever I can, and especially with the repeated TESE for the unfavorable outcomes such as the ESCOs. And if the case decided to do the FNA mapping prior to the private mTESE, then I will focus on the so-called sperm heat map. So it is basically the location where we found the sperm based on the mapping. So, and according to the research and the testes with the mature sperms, more likely found in the testis periphery rather than the centrally.
Perfect. Thank you. All right. So we've talked about this a little bit, so I don't want to take too much time, but hormonal optimization, medical therapy prior to repeat micro-TESE. Professor Salonia, you recently authored a meta-analysis on this. Can you give us your insights?
Indeed, you clearly outlined the point that according to the meta-analysis, although there are bias for each one of the findings, as you know, according to what has been published before, but what we found was that clearly there is a sort of dichotomization. If you do have normal gonadotropins and normal pre-op testosterone level, you may find something more whenever you are going to promote therapy with gonadotropins, which is not the case for those suffering from primary hypogonadism, thus meaning hypergonadotropic hypogonadism. Data do not suggest any kind of improvement whenever you're going to provide our patients with. And therefore, in terms of recommendation, there is a strong recommendation whenever you do have normal values before. It is an against recommendation whenever you're going to having a primary hypogonadism. That is the data coming from the meta-analysis.
Perfect. Thank you. So let's move on. And so which order would you recommend proceeding with the repeat micro-TESE? Would you prefer to do a fresh sperm, fresh egg cycle, do an egg retrieval first and then freeze the eggs and do a delayed micro-TESE, or do micro-TESE ahead of time, freeze sperm that are found, and then do a delayed ICSI cycle? And it seems like our panelists have differing opinions. So Dr. Kolpi, please give us your thoughts.
Well, I was obliged to perform cryopreservation of a sperm after performing successful micro-TESE for many years because I had no possibility of performing at the same time an ICSI procedure. But really, in this moment, I have been working for more than 2 years and a half in this center where I put together in the same theaters, in the same day, in the same morning, I can perform micro-TESE and ICSI. And really, it is, in my opinion, this may guarantee a better result because in many cases of non-ostatic azoospermia, the successful micro-TESE is obtained with a very poor number of sperm retrieved. And after cryopreservation, you can lose a lot of these sperm. According to the literature, more than one half in these some cases, some authors support explain that about from 50 to 70% of the sperm are lost after cryopreservation, and this in case of a poor positive retrieval, this may hamper the result of the success of the subsequent ICSI procedure. So really, in this moment, I prefer to perform always, whenever it is possible, fresh micro-TESE plus ICSI.
Okay.
Can you wrap up, Professor Rampatla, because you have 12 minutes time for the discussion, yeah.
Sure. Okay. And so our last question deals with what complications can occur with the repeat micro-TESE. And I think the panelists were all agreeable that you can get hypogonadism, decrease in testicular volume, and hematoma, devascularization of the testes, especially in a repeat procedure. And with that, I'd like to thank all our panelists today. And we can see that, you know, there are differing opinions in these tough cases, but this is exactly why we need more research, more studies, and better guidelines to help guide clinicians forward with these tough scenarios. Thank you.
Professor Shah, can you announce the moderator and the panelist of the second case, please?
Yeah, could we start with the second case? Professor Panko?
Oh, yes. Thank you. Yeah. Can you see my slide?
Yes.
Yeah. First of all, I would like to congratulate Professor Agarwal, Professor Dioglu, and Dr. Rubinka for the excellent program. For this second case discussion, I would like to present a case management of non-obstructive azoospermia with primary testicular failure. We want to talk about the fresh versus frozen testicular sperm. I would like to invite Professor Ahamoda from Saudi Arabia and Professor Murad Gul from Turkey and Professor Fotis Dimitriadis from Greece. This is a 37 years old man with his healthy 35 years old wife. They are married for 7 years and consists of no children. About the wife, has a normal menstrual cycle. AMH level is a little bit low, 1.2, but a negative SHC. The husband, from medical and surgical history, there is nothing is important, but from the physical examination, normal epididymis and no enlargement, both testicles are firm on palpation without any nodules. Right testicle is 14 cc and left testicle is 15 cc. From the hormonal assessment, the FSH is a little bit high, 15, LH is 11, total testosterone is 250, below the normal limit. And from the semen analysis, there is no sperm or azoospermia. From the genetic, there is no abnormality, there is no microdeletion. Now we are going to have the first discussion about the patient more like to have primary spermatic failure, hypo. Are you going to offer the following therapies preoperatively? I would like to invite Professor Taha, please, your comment, whether are you going to offer this or not.
Yes, thank you very much, Professor Ponko. I'm sorry, I have technical error with the video. To answer your question, I think we need to put all the important pieces together. This is a 35 years old man with proven azoospermia and hypergonadotropic hypogonadism. And he has borderline small testicles and no chromosomal abnormalities. Importantly, on the other hand, his wife, she is 35 years old. And at this age, we should put a big concern about her fertility potential. However, she still having more or less adequate ovarian reserve. So to answer your question, there is, of course, there is no right and wrong answer based on that there is no clear guidelines and no high quality studies to support any opinion to optimize versus not to optimize, no randomized controlled trials, at least for now, I'm not aware of any of them. So for this particular couple, I will counsel the patient, explain to the patients the pros and cons of optimization. And I would recommend starting with them to optimize this patient maximally. I think a delay of the surgery for 3 months might not harm the fertility potential of the lady and may improve the likelihood for finding sperm during the micro-TC. So for this couple, I will advise clomiphene citrate to raise his testosterone and improve his hypogonadism, and I may also add FSH. Importantly, I should explain to the patient this is a pragmatic approach. This is not based on high quality studies or strong recommendations of the guidelines.
Thank you.
For antioxidants, I'm sorry, for antioxidants, I don't believe the antioxidant would help this couple, and because it wouldn't improve the quality of the testicular sperm. Probably for ejaculate sperm, yes, but for testicular sperm, I'm not aware of any study supporting the use of antioxidants to improve the quality of testicular sperm in micro-tissue.
Okay, thank you, Professor Taha.
Thank you.
I would like to invite Dr. Gu to share your thoughts about this.
Yeah, thank you very much. I am totally agree with Dr. Taha. But also I would like to say that if this case was a hypogonotropic hypogonadism, I would definitely use one of these treatment options. But in this case, either I go with the direct surgery or for a short time, I may think to search the testosterone levels with the LH analog treatment, like beta HCG treatments, but just for a short time because of the couple's condition, then go with the surgery. So this is really, I mean, debate continues on this topic, and this topic should be constant with the couples.
Okay, thank you, Dr. Gun. I would like to invite Dr. Dimitriadis.
Yes, thank you, Professor Bonko, for the opportunity. Well, without checking the total oxidant or reductive potential of this patient, I wouldn't go for antioxidants. Clomiphene citrate is a more empirical treatment with no guarantee results. So with a lady of 35-year-old and low anti-Mullerian hormone, I wouldn't go for that. And as for the hormonal optimization, no. For a hypergonadotrophic hypogonadism men, I wouldn't advise the couple to lose extra months for such a treatment without any guarantee or without any strong, robust data through a meta-analysis or other to perform it. So I wouldn't prefer neither of that treatments.
Okay, thank you, Professor Dimitriadis. As Dr. Taha said before, there is no right or wrong answer in this case, but we can see the thought for every panelist. So this is the intraoperative findings, and then considering the patient has no borderline small testicle, which approach do you prefer, and what is the pro and cons between conventional TC and micro TC? Are you going to doing the additional FN mapping or another approach? Please, Professor Dimitriadis.
Well, as for these questions, we have two testes with medium size, so I wouldn't go for a conventional TESE in order to not to lose more testicular parenchyma. So I would go to micro TESE, so it will less damage for the testes. FNA is out of question in my department and in my strategy. Other approaches, yes, I would like to try first in the spermatic cord to make there an aspiration from there. And if I wouldn't find any spermatozoa there, then I would go directly to micro-TESE.
Thank you. May I invite Professor Gu to give your opinion?
Yeah, I agree with Dr. Fotios. I would continue with micro-TESE. But I am also aware that there's a very recent systematic review and meta-analysis by Dr. Giovanni and his colleagues, and they show that the conventional TESE and the micro-TESE has similar sperm retrieval rate and the pregnancy rates, but in my clinical practice, I would always choose micro-TESE.
Okay, thank you. Professor Taha, may you share your thoughts about it?
Yes, I do agree with Professor Photius and Professor Gul that I will go for micro-TC and not conventional TC. This patient already has hypogonadism. So the conventional TC will remove gross amounts of testicular tissue, and this will further jeopardize the testicular function. So no question, we will recommend the micro-TC.
Okay, thank you, Professor Taha. We are going to move to the next question. This is interesting because considering the female partner is now 35 years old with MSS 1.2, which approach do you prefer? Fresh or frozen micro-TC? Please, Professor Gul, maybe I invite you first.
Well, thank you. This is a really interesting question, and actually debate continues on this topic. Some authors says that the poorer its results with thawed sperm compared to fresh one, but the recent systematic analysis and meta-analysis showed that the difference is not very significant. So I believe that the advantages and the disadvantages of both techniques should be consulted with the couples, and we should proceed accordingly. I usually use fresh sperm with the HC. Yeah. Thank you.
Okay, thank you. Professor Dimitriadis, maybe you have another.
Well, you know, they say that the man has always to wait for her lady to be ready. So I would go for a frozen micro-TESE and not for a fresh. But here we have an interesting case. The woman has a low anti-Müllerian hormone. It's not sure if we find any oocytes ready to be fertilized. And on the other hand, we do not know if we find spermatozoa. We have at the best 50% chances to find spermatozoa. So if the couple agrees to go with donor sperm, then I would also suggest the fresh sperm. So to get ready the lady and pick up the oocytes, and if we don't find a good sperm, and if the oocytes are of good quality, then the couple continues with the donor sperm and don't loses the chance to get pregnant. If they do not agree with this scenario of their own biological offspring, then I would go for a frozen micro-TESE without the stress of the oocyte that is waiting for me, and it is getting old, and to have all the time I want, the 1, 2, 2.5 hours until to find the spermatozoa and froze it.
Thank you, Professor Dimitriadis. I would like to invite Professor Taha to emphasize about the sperm donor. What do you think about that too? Prepare also the sperm donor.
Yes. In fact, using fresh or frozen is debatable in non-obstructive azoospermia. If the same question on obstructive, of course, we'll use frozen, fresh sperm. But here, every one of them, every technique has its own advantage and disadvantage. Of course, using the frozen sperm will expose the sperm to excessive stress during the freeze and the thawing process, and we lose a significant proportion of the sperm, and we already have few sperm to start with. But in our institution, our policy in most of the circumstances, we use frozen micro-TC because frozen sperm, because we don't have donor backup. We are not allowed here in our countries to use a donor sperm. So if there is a low chance to find sperm, around 50% chance to find sperm during the micro-TC, I will expose the wife to unnecessary risk for ovarian stimulation and at the end we may not find the sperm. So I prefer, and our policy is to use frozen sperm and then prepare the wife if we get the sperm.
Yeah, thank you, Professor Ta. It's getting hot, the discussion, and then we go to the discussion for after we do the microTESE, but there's no sperm. What are you going to do next to the patient? Are you going to the testicular histopathology testing, FNM mapping, repeat the TC, medical hormone exploration, or another approach? Maybe I invite Professor Taha first to give your opinion. If there's no sperm, and then what you're going to do?
Okay. Testicular histopathology testing, this is routinely done during the first procedure. And repeat TC, yes, we can discuss with the patient, with the couple repeating the micro TC. If the couple or the male partner has not received any optimization, we may try to optimize this patient for 3 to 6 months before embarking on another redo surgery. Other approach, donor, we don't have the donor. Other countries may have the donor as an option.
Yeah. Professor Dimitriadis, you said you are not going to lose another month, but how about the medical hormone evaluation or treatment after we failed for the mTESE?
Well,
yeah. I'm sorry.
Well, still, I wouldn't go for any medical or hormonal evaluation, depending also from the histopathological condition of the testis. I always give an histopathologic sample to go for the histopathology. And if here we have a Sertoli cell-only syndrome, for example, I wouldn't go for sure for medical or hormonal evaluation. On the other hand, if I have an histopathology with a Johnson score 10, for example, so they found spermatozoa, then I would go immediately for a repeat TESE. Otherwise, I would go for a repeat TESE after 3 or 6 months. FNA mapping or other approaches, no, I wouldn't suggest anything else.
Thank you, Dr. Dimitriadis. Professor Moll, are you going to do the repeat TC, and when is the best time to do the repeat TC, Professor Moll?
I think I would wait for at least 6 months or to redo the surgery. But sometimes the couples may ask to have medical therapy because they heard somewhere else and they would like to try the medical therapy. So while I am waiting the repeat TESE, I may sometimes try medical or hormonal evaluation. I mean, slightly increase the testosterone levels and balance the patient's gonadotropins, and I do the repeat TESE after 6 months from the first TC. Yeah.
Can you conclude, please? We are a little bit behind the schedule. We are 4 minutes behind the schedule. Can you conclude, please?
Yes, please. As we discussed before, there is no right or wrong answer in this case, depending on the situation of the patient and also the condition of the local condition. I mean, local condition, like in Professor Taha countries, we don't have, our Muslim country, we don't have donor sperm. So donor sperm is not one of our option in this case. So we talking of the debate about the something is not stated in the guideline, but the experience from the panelists can be one of our consideration to treat our patient. Thank you, Professor Tadulum. I return it to the moderator.
Thank you very much, Professor Birova, Hamada Gül Dimitriadis. We move to the third case, and the leader of this panel is Professor Altay from Turkey, and the panelists are consisting of Professor Chayan, again Turkey, Lukman Hakim, Indonesia, and Tan Lee, Vietnam. Professor Altay, go ahead, please. You have 12 minutes time.
Good evening, dear Chairman and colleagues. I send my best wishes from Antalya, and I invite all the GAF members to attend our annual meetings in Turkey, and I'm very happy to be part of Turkish Urology Association and Global Andrology Forum collaboration. I will moderate this case. It's a Klinefelter case, and I will moderate with three panelists as Dr. Kadıoğlu presented, Dr. Hakim, Dr. Chayan, and Dr. Lee. And the case is, he is 28 years old with a history of 3 years marriage, and he referred to the infertility center, and they plan to have a child for a year. His wife is a healthy woman, 26 years old, young lady. He had a smoking habitus, one pack for 10 years, no surgical history, no erection and ejaculation disorder. However, he suffers from lack of interest in sexual activities. And his physical findings, he is rather tall, 187 centimeters, and weight for 107 kilograms, and body mass index is 31. For the inspection, sparse body hair, mild gynecomastia, increased waist circumference, and for the scrotal examination, both tests are 4 cc in the scrotum, no clinical varicocele, and vas deferens are both palpable. And semen analysis 2 times with 1.5 and 1.4 cc with azoospermia. Dr. Hakim, which hormonal analyses do we need? And these are the findings of this patient.
Yeah, thank you, Professor. As we can see, can you hear my voice? Yeah, okay. As we can see that this patient has high FSH, LH, and estradiol, while prolactin, total testosterone, and ratio of testosterone to estradiol are low. Now, what kind of, just a minute, a bit sorry about this. Can you hear my voice?
Yeah, we hear you.
Yeah, based on the AUA and ACE-SRM guideline on male infertility, basically the FSH and testosterone are indicated for infertile men with impaired libido, erectile dysfunction, oligospermia or azoospermia, atrophic testis or evidence of hormonal abnormality during physical testing, as we can see some in this patient. And next, if the fasting morning total testosterone level is low, less than 300 nanogram per deciliter, a repeat measurement of total testosterone is recommended, and also a measurement of the serum luteinizing hormone, estradiol, and prolactin. Now, next I would like to add about karyotyping and Y chromosome microdeletion, which is going to be the next question. These two genetic testing should be recommended for men with primary infertility and azoospermia or severe oligospermia with elevated FSH or testicular atrophy of impaired sperm production as a cause of azoospermia. Can we have the next slide, please, Professor?
And also, Dr. Hakim, do we need genetic analysis for this patient?
Yes, we can see here that the result of genetic testing in these patients are karyotype 46XXY, Klinefelter syndrome, and there were no Y microsome microdeletion were found. Now, basically, the genetic analysis is necessary for primary infertility and azoospermia or severe oligospermia with elevated FSH or testicular atrophy patient, as mentioned in the earlier slides. And one reason to this is to identify any genetic alterations, such as Klinefelter in this case, where the addition of X chromosome to male karyotype of 46XY may result in the progressive testicular damage, and this may be the cause of impaired sperm production and fertility, such in this case. And as we can see in the slide, that the prevalence of azoospermic patients varies between studies, but generally it ranges between 10 to 20%. Now, the Y chromosome microdeletion is also important to identify, since a different segment of deleted azoospermia factor has implications for assisted reproductive technologies. Men with azoospermic factor C deletion, for instance, have a positive prognosis for finding sperm sufficient for assisted reproduction compared to other segments.
Thank you, Dr. Hakim. And the next question is for Dr. Chan. What's the success rate with microTESE in Klinefelter patients?
Thank you, Professor Baris Entay. The next slide for me, please.
About 2/3 of men with Klinefelter syndrome are hypogonadal, just meaning testosterone level of less than 300 nanogram per deciliter, as our cases has. Because hypogonadism might increase prevalence of adverse cardiovascular, metabolic, and bone-related conditions, in a systematic review and meta-analysis, including about 43 papers with more than 2,000 patients and controls, patients with Klinefelter syndrome showed worse metabolic profiles. So therefore, testosterone treatment might increase bone mineral density and decrease cholesterol levels and body mass index and weight circumference. Just going back to the answer of the question and looking at the literature to see reports of outcomes of medical treatment to increase testosterone level before micro-TC in men with Klinefelter syndrome. In the first paper by Dr. Corona from Italy, they found no sufficient data to evaluate the effect of previous testosterone level on testicular sperm retrieval rate. However, in another meta-analysis by Dr. Machaut, including 53 studies with more than 2,000 patients with Klinefelter syndrome, they found about 38% of sperm retrieval rate. They found also that younger age and higher testosterone level were a favorable predictor in men undergoing testicular sperm extraction procedures. We have published a multicentric study with about 400 patients with Klinefelter syndrome. We found testicular sperm rate of 57% after micro-TC procedure. As testosterone level increased and sperm retrieval rate also increased. So therefore, receiving medical treatment prior to micro-TC was a positive factor for both achieving pregnancy and successful sperm rate. Going back to the patients, if we really should offer the patients to increase testosterone level, his testosterone level was about 158 nanogram per deciliter, so which is highly less than normal range. So, and also the patient has testosterone to estrogen ratio of less than 10. So it means I will prefer the patient testosterone level to increase at least more than 200 nanogram per deciliter. The first choice for me would be one of the aromatase inhibitors because the testosterone to estradiol level was less than 10 in that patient. The second choice, maybe if the testosterone to estradiol ratio was more than 10, then my second choice will be giving the patients achieving testosterone level to at least more than 200 nanogram deciliter with one of the gonadotropins like ACG.
Thank you, Dr. Chan. And Dr. Lee, what's the ideal time for micro-TESE for Klinefelter patients?
Yes, we can see that the success rate of the mTESE is ranged from 10% to 50%, and especially it's higher in the younger patient and less severe testicular damage. If you look at the table below, you can see that the sperm retrieval rate success in the adolescent age from 15 to 19 years is 45% in one research. And this rate in the adolescent age from 13 to 14 years is just 10%. And it would be best for us to do the mTESE in the age of the patient of mTESE Klinefelter syndrome before the age of 30. The next slide, please. And the success rate of successful rate depends on the experience of a surgeon and an embryologist. And when we do the testicular biopsies during adolescence, we will have the damaging effect on the fetal success rate for the sperm retrieval rate and will decrease in testosterone level. So it still have the ethical controversy here. For the EAA guideline, they recommended information on fertility issues to the Klinefelter syndrome adolescent patient and his parents as well. And they suggested that the semen collection in the adolescent with Klinefelter syndrome after careful information and might undergo a testicular sperm expression.
And finally, what's your opinion about PGD during ICSI procedure in Klinefelter patients?
Yes, as we know that the incidence rate of abnormal gamete formation is very low. It's less than 1 to 3%. So there's no difference between the PGD and the control group. And the PGD technique may increase the risk of miscarriage. So now some non-invasive PGD techniques like the NGS and the trophectoderm biopsy, they can provide a good prognostic outcome and significantly reduce the adverse effect. Thank you.
Thank you. Your answer, Dr. Lee. And finally, we can conclude that from this panel, testicular volume and FSH values are not predictive factors, and experience of urologists and both embryologists increases sperm retrieval rates. Men older than 35 years rather have a low sperm retrieval rate than young Klinefelter patients, and intratesticular testosterone levels are associated with spermatogenesis, and stopping testosterone replacement therapy and empirical hormonal stimulation might improve outcomes of microTESE. However, more standardized protocols are needed for evidence-based medicine. Thank you.
Thank you, Professor Altay, Professor Chayan, Professor Hakim, Professor Lee, for this nice discussion and also keeping on time. We proceed to the last case, which will be moderated by Vinay Malhotra. Manav Al-Hashimi from India is Professor Malhotra. Manav Al-Hashimi from United Arab Emirates. Germar Michael Pingara from Austria. And Imad Ziu from Morocco will be panelists. Please go ahead, Professor Malhotra.
Thank you so much, Dr. Ratesh and Professor Ashok for this kind invitation. And I'll share my screen so that we can begin with our presentation now. So this is the final case, and we have a very esteemed panel today, Dr. Manav, Dr. Pingera, and Dr. Imad, and we'll quickly begin with our case, which is a 26-year-old gentleman with a 25-year-old wife, primary infertility of 2 years, azoospermia proved by several reports, including a centrifuged pellet, no significant past history. The wife has a normal exam. The husband also has a history that's unremarkable, and an examination has a 10 ml testis bilaterally, which is soft. The epididymis is flabby, the vas is palpable, and there's no varicocele. So we have 3 different scenarios here, and we'll take up one scenario at a time with the panelist. So, Dr. Manav, if the report of FSH was 3, his LH 2.5, a total testosterone of 550 nanogram per deciliter and an estradiol of 20, what would be, we'll come to this, sorry. Would you optimize prior to surgical sperm retrieval at all? That's the first question to you. What will you decide and why? And what is the evidence and recommendation do you believe? Please.
Okay, thank you very much for invitation for everyone, and regards from Abu Dhabi United Arab Emirates for everyone. I would repeat the many of comments about hormonal treatment for these cases. Definitely, the evidences are very clear. The hormonal treatment have evidence base only if there is hypogonadotrophic hypogonadism. And the other cases, we have little evidence based on, let's say, studies that are weak evidence and recommendation only consider the recommendation C. These factors involve if there is any normal gonadotropin and normal testosterone in this case. So this case represents normal gonadotropin and normal testosterone. The evidence to support hormonal treatment is weak, and there are some remarkable factors that can enhance or can give suggestions for hormonal treatment for this case, especially if the patient have a previous testicular biopsy showed hypospermatogenesis or late spermatogenic arrest. In these cases, we need to discuss the patient the weighting the hormonal treatment against the of course the cost and the low efficacy to increase the sperm retrieval rate. So if the patient agreed that there is low evidence and still he preferred to go for the treatment, of course the options of the treatment either HCG or clomiphene citrate as what is called the steroid or estrogen receptors modulators, and mostly like sometimes if there is estradiol is high and not in this case, then aromatase inhibitor. So in this case, the evidence supports the treatment, hormonal treatment with low success rate for increased sperm retrieval rate. Thank you very much.
Thank you so much, Dr. Manav. Now, Professor Pinguera, the report for the gentleman came out with the FSH of 28 and LH of 9, a total testosterone of 200 and an estradiol of 40. Again, the same questions for you. Do you optimize before surgical sperm retrieval? If you would optimize, what kind of therapy, when would you initiate, and what do you think are the current evidences, guidelines, and recommendations?
There's two issues. We have only a few information from the patients, and these patients have small testicles. And furthermore, we get only the results from one hormonal assessment. So results 2 is FSH 28, really high, hypergonadotropic, and hypergonadismus. The problem is he has a low testosterone. That makes it cause really difficult to understand what we should do, because until now we discussed always the cases of hypergonadotropic hypergonadismus, which have of course to clear or to treat. Different is of course clear that a certain kind of gonadotropic therapy is only indicated in the treatment for normal gonadotropous idiopathic infertility. This is considered experimental in most of the countries, and still the data are not clear. So even at the recent meta-analyses have shown that FSH might increase some pregnancy rate in the females and partners of these patients, but the effect size is really low. So that means that we have to deal with a really tough situations, because we have a young patient, a young couple, which are interested in having a child. And if I'm looking to the total testosterone from 200 and the estradiol given with 40, I guess, picograms per milliliter, so that if I'm calculating right, then we have here around the ratio from testosterone estradiol to from nearly 15. So at this again is a tough situation. Are we going to hyperstimulate and burn out in some kinds of testicle? Can we risk it or not? So on the end of the day, what should we do? I think there is surely an option to treat these cases, because they are a apparently proved several times to be azoospermics, and they both couples have the child, want to have a children. So one up would be, of course, to try in this exceptional case with some kind of gonadotropins, and then look exactly what is happening is the estradiol, because that's a 14, so high estradiol will increase probably. And if estradiol is going to increase, we have to monitor it closely, I think in 4 weeks after starting any therapy. And then we have to monitorize and maybe to reduce it with some kind of anastrozole or letrozole, what else your country is advised to reduce it. Because basically the next problem which is arising right now, what I'm seeing here, that there is new studies showing that the problem is with the P450 aromatase in the testicle, which is not, which is clearly the most problem for the concentration of the intratesticular estradiol concentration. So we must be aware that what we are measuring here in the patient is the serum testosterone, the systemic testosterone levels or the systemic estradiol concentration, which is definitely not the same which we are looking for the intratesticular situation. So here we have to be carefully, and I think the relation from the Leydig cells and the circular cells have to be in really good monitors. If not, we are going to risk a little bit with the patients, and we have no good outcome if we are trying to go for the TZ. Basically, if it's going fine, we can monitor his estradiol with gonadotropic stimulation therapy. Then I would advise at least to go for a certain period so that we have a fine testosterone. Ideal would be, of course, over 3. In my case, I would prefer to try to bring this testicle to a testosterone between 4 or 5, something like that. This range higher or 8, 9 is a contraindication. You should never do that. You should stop it immediately. You should monitorize it closely, the therapy plan, and then I think you have an option that you can have a little bit better outcome in a micro-TZ, of course.
Thank you, Professor. Moving to you, Dr. Imad, you have the third scenario where the FSH is 8, the LH is 5, the total testosterone is 300, and an estradiol of 25.
Thank you, Dr. Vineet. Thank you, Dr. Vineet, and hello, everyone. As we see, hormonal profile in this scenario does not show any anomaly. So FSH, testosterone are normal, and estradiol not elevated, and also the ratio estradiol per testosterone not elevated as well. So I will not optimize by hormonal therapy in this case before micro-TZ, given the absence of evidence supporting this, and also the normal values of reproductive hormones. And also it is not recommended by the EAU guidelines. Thank you.
So one of the questions that we would want to know here, and I'll start with you, Dr. Manaf, here. You have a situation of eugonadotropic versus hypergonadotropic, hypogonadism or borderline normal testosterone level, which is in the plasma testosterone. Would you consider hormonal therapy as in the case that was shared in the third scenario?
Okay, thank you. So whenever the patient's having low testosterone, and especially if the patient is symptomatic, this is actually one of the indications of hormonal treatment. And we need always, we can start the treatment definitely, but always we need to look for the testosterone estradiol ratio, because this can modulate your treatment. So SCG is one of the modality of the treatment, or clomifene citrate. If the estradiol is increased, or the ratio between estradiol and testosterone is increased, then aromatase inhibitor could be an indication. The duration of treatment usually at least for to get on significant intratesticular testosterone, especially before TESE, we need at least 3 months to cover hormonal manipulation before TESE.
And the third question also, because this is something which we would want all panelists to give a view on. Do you consider any regenerative therapy?
Actually, there is no evidence based in my practice. I'm not doing.
Right. Professor Pinguera, the same questions to you, please.
Well, the evidence for an FSH treatment in a normal gonadotropic patient is far restricted to idiopathic infertility, which means that it's not identifiable. General accepted cause for male infertility could be detected. So this is not the case. But again, I'm supporting the idea that we have only one value, and now we have one testosterone around 300, which is really exactly borderline. Are you sure that this is the best of his testosterone? Is it reflecting his normal situation, or maybe this was an exception best case and normally he's hypergonadotropic? So again, it's strongly advisable according to the guidelines to have a recheck according to the guidelines. We measure in the morning fasting morning between 8 and 10 p.m. and maybe in a fasting situation, because there's an influence from insulin to this testosterone production too. So check it before and you make a decision, and then you can find a better solution. On the other side, of course, the ideal is always to see what's the relation between testosterone and estradiol, as stated before, and I agree with Manav. So here we have the option, of course, to use clomifencitrat 2 in the case of, but here again, it depends from this ratio. Elsewhere, you're going in the wrong direction.
And with regards to regenerative therapy, your ideas?
I'm sorry, the question, please.
No, Professor, do you consider any regenerative therapy?
Any regenerative? Okay, so this is a promising approach, but for clinical routine practice, it is not truly recommended right now. But stem cell therapy, surely it will be a very promising approach.
So if we were to summarize broadly, I think current guidelines, we don't have recommendations stronger than weak recommendations to consider after proper counseling by some guidelines. As we saw with the American guidelines, the European guidelines do not recommend the use of hormone therapy prior to sperm retrieval with micro-TESE and non-obstructive azoospermics. Even the Indian guidelines do not recommend them. This has to be a consensus situation, which means proper counseling of the patient. Since this is kind of a desperate situation, in desperate situations, minor indications can also become useful. And as we've seen, the evidence for men with eugonadotropic hypogonadism is stronger than the lack of evidence for the hypergonadotropic men. Possible use of gonadotropin therapy here in the form of HCG initially and then followed by recombinant FSH is something that has been recommended. And again, we've got to individualize these cases. These are very tricky situations. You have to be certain that when you consider a plasma testosterone level that is representative, some would like to use 17-hydroxyprogesterone as a better marker of the intratesticular testosterone measurements. And there's a variety. So you've got to individualize where you've got to think of this patient that's possibly not going to have another chance of using native sperm, and where the use of donor sperm is absolutely prohibited. Doing anything may be worthwhile. So I'd like to hand this back to you, Dr. Atish, and thank you so much for the evening.
Thank you very much, Professor Malhotra, Hashimi, Pinguera, and Ziuziu for this nice discussion. At the very end of this of the webinar, Professor Shah and myself, we are going to give some take-home messages. I'd like to start first. As the first talk, Dr. Kadıoğlu underlined the importance of the intralobular anatomy, arterial anatomy, by during the micro-TESE, and care should be taken not compromise the testicular arteries. And Dr. Rubin Shah, in his talk, he discussed horizontal versus longitudinal technique, advantage and disadvantage, and also he discussed the single tubule technique, which was recently introduced. And would you like to continue for the next speaker, Professor Shah, please?
Yes, so then we had additional discussions on the methodology of sperm preparation in the laboratory, with a greater emphasis on the use of erythrocyte lysing buffer and enzymatic digestion to increase the chances of sperm retrieval. And we also had a discussion on the role of hormone therapy and whether it would be useful, especially in cases of failed micro-TESE. So I think if you were to summarize the discussion, it's been a very interesting discussion, and one of the highlights has been the divergence of opinion, especially when it came to hormonal therapy. In terms of the indication for micro-TESE, there seems to be general consensus that that is the best way to go in cases of testicular failure, but whether such patients would benefit from pre-procedural preparation and which drug to use still remains controversial. Muhammad Arafa did point out some logic to the possibility of using HCG alone or HCG followed by FSH and sometimes clomiphene. And I think the participants have been given enough thought for planning their own future therapeutic regimens when dealing with these very difficult cases. So once again, it's back to you, Professor, for the last word and to thank the panelists for an excellent job which they have done today.
Yes, last but not least, Professor Sofokidis discussed the technique in cases with high DNA damage in the ejaculate and the choice of micro-TESE or TESE can increase the fertilization rate. So I think it was an excellent program under the leadership of Professor Agarwal. As Turkish, on behalf of Turkish Society of Urology, we like to thank to the GAF members, Professor Agarwal, and for the academic contribution of the moderators and panelists and speakers at this webinar, and give the last word to Professor Agarwal to conclude. Professor Agarwal, please.
Thank you very much, Professor Kadiolu. Thank you very much to each and every one of our speakers, our moderators, and the panelists. I believe that this is one of the most beautiful program that we have seen in all these years. And I have seen very, very good comments and feedback received already. So I believe that we were able to provide answers to many complicated situations and cases by having this kind of forum where the cases were discussed and the discussions with the experts were able to provide a variety of ways for doing things as we see that there is a lack of society guidelines or clarity because of situations which are difficult to standardize. So I think this was a wonderful presentation. Thank you very much for our IT support team for doing a great job. I just wanted to leave two messages before we end today. One is the website or the link to complete the post-test questionnaire, multiple choice is now open. For all of you who have taken the pre-test, you will be allowed to take the post-test, and it will be open until Monday. So you have 2-3 days to complete this. So please do that. And then the second thing is the organizers are going to provide you the link to do a satisfaction survey. Once you complete that survey, you will be able to click and get a certificate of attendance. But those who take the multiple choice exam, and if they score more than 75 or more, they will be able to get a certificate of training. Before we started this program, I saw almost 260 people who have registered have taken the test, and many more wanted to take the test, but we had closed the link. So this concludes our program. And again, thank you very much to everyone who's listening to this program. You will be able to get a video recording of this in the next few days once the video is ready. Thank you, Professor Atish, and all your team, everyone of our faculty for doing a fantastic job. Thank you and have a wonderful day. Thank you. Take care. Bye-bye.
Bye-bye. Bye-bye. Thank you.